Yeah, thank you, folks, for joining us and welcoming you all to this fourth webinar of SocioDent. We've been doing this from the beginning of this year, and we want to continue it throughout this year. And we want to inspire how many ever people join us. We are not very much bothered about it. We are just want to make people learn. And so, just a brief, very brief introduction about SocioDent. We are an early stage startup. So, our vision is to redefine oral healthcare through our innovations. And we are primarily developing a product for those who cannot brush by themselves. As you can see, I've just put a very brief image of it. So, we are developing a mouthpiece based oral hygiene device for these people who are unable to brush by themselves. You can imagine dependent people, persons with disabilities, geriatric individuals. Look, there are a lot of people in India like that. So we are developing this device, and we have finished the prototype. We are going for clinical trials. We got some fundings. So these are our social media communication channels. In case any of you want to reach out to us, you can also reach out on our email address, and our address is at IIT Chennai. So without further ado, I'll introduce our speaker for the day. So I'm very happy to have my senior. I have seen senior meaning when I was doing UG, so I was doing PG, and then I was actually fortunate to assist him and help around with sir in his clinical cases and all that. I've seen is very meticulous in planning each of the cases that he does, be it a simple impaction or some jaw surgery or implants and all that. I've witnessed some of that from the side, and I'm very happy, sir. Thank you for joining us, and thank you for giving your time on a Tuesday. I know your consultation schedules are very busy. So just to brief about sir, he is a board certified implantologist, both international board and national board. He's working as a teacher and a senior professor, senior lecturer at, I think, reader probably, at our Ragas Dental College here in Chennai. And the topic for today, in case you didn't look it up before while registering for the webinar, is we are going to demystify. We're going to try and demystify implantology for some of you. I know all of you heard that much. Maybe some of you are trying to do implants, you're doing implants, but still you want to learn. So we are going to demystify, break it down into simpler pieces. Maybe some of the things that sir is going to talk about, maybe you may already know it, but it will be a reflection and a reaffirmation for you. And sir would also be sharing some practical case studies from his experience and all that. So, and I would also request sir to briefly introduce his accomplishments, of anything so far. So thanks a lot, sir. Thanks a lot for joining us. And this is your time. Take it over and please inspire us. Sir. Thank you.
Is my screen visible?
Yes, sir. Your screen is visible.
At the outset, thanks very much, Stuart, for the kind words. I don't think I have accomplished so much so as to tell about myself, but thank you for your kind words. Now, and congratulations first to you on a very good, your motive is very good. Your intention is great. And I wish you all my best for your venture. All the very best. Now, thank you for the invite as well. And it has been very new to me. You have asked me to talk about implantology for beginners. Now, what I find in people who are learning implants or who are practicing implants initially is they have a lot of misconceptions or fears about the various jargons or various technical terms. They don't understand what it is. The real part is actually the entire concept is very simple. The only thing is you need to understand what you're doing and when you're supposed to do, and most importantly, when you're not supposed to do. Just because you know implants are not meant for everybody and not for every clinical situation. There are certain situations which demands that implants should not be placed. So it requires a certain set of learning, a certain set of understanding of various concepts. Now, I hope I'll take the participants through a brief lecture about the various components of implantology, the various insets. So what is an implant, how is it done, and what are the idea behind it. So with this brief introduction, let me go into the presentation. So I'll be speaking under the following headings. First, a brief introduction, following by a most important parameter in implant cases, a case selection. Right case will make a big difference. So there is no point in jumping and doing heroic ventures in cases which are not meant for implantology. So how to do a proper case selection and a proper implant planning, which is equally important. It is not that you take a screw and place it in the bone wherever there is space. And a point which has to be emphasized is you get proper implant training. You need to learn it well, which will include definitely about various armamentarium which have been implant armamentariums which have been introduced. And of late, there are many recent nuances. There is the new devices have been introduced in the field of implantology, which you should be aware of. And very importantly, it is not on the clinical part. You have to rely a lot on the lab communication also. So we make sure that you have your processes done and fabricated by a lab, by a technician who is well versed in implantology and who does implantology frequently. It is not meant for the occasional technician who does not know or not trained in implantology. What happens most of the time is I find that people are not educating the patient properly. So a patient walks in, you find a idental space. Now all that you see is idental space, and your mind is fixed on an implant. You do you put all your efforts to somehow convince the patient for an implant. You put the implant, but what you fail to do is you do not educate the patient. You need to tell about the implant, the possible complications, the possible success rates, what to expect, what not to expect, and in case if the implant fails, what is the other alternative option. Now all these should be explained to the patient. And you should definitely explain about implant failures and its complication. I have seen most of them saying that an FPD is temporary and you give an implant, it is for life. That is absolute misnomer. Implant is not for life. It can extend a lifetime, but it is not in all cases and not for all patients. And very important is financial and legal considerations. You need to sit down the patient, talk to the patient, explain about all the various financial costs, all the costs, right from the implant cost to the component, to the lab fees, in case if you are calling a consultant, the consultant fees, and including the cost for post-operative maintenance also. And with all this, I would like to, at the end, I would like to conclude giving a brief introduction about all those things. So with this, let us start. So I'm sure that most of you are aware, dental implants are nothing but, in simple terms, a screw made out of titanium. Okay, a screw made out of titanium with the sole intention of replacing a tooth. Be very specific, to replace a root. Okay, so you'll be giving a crown on top of it. Now, what is so special about this titanium? It is not like any other material that you can. It is not like a steel that you take a screw and screw it onto the bone. This titanium has got various properties, various biocompatible properties, out of which the most important property which we address is something called as osseointegration. Now, what you see in the picture on the right is a close-up picture of the interface between an implant and the bone. Okay, this is what we expect in implantology. Now, this is called as osseointegration, nothing but the union between a bone and the implant. So this, if you achieve osseointegration, your first phase is done. One more feature which is very important in implantology is it is something you can compare it to a building. Okay, imagine you are planning for construction of a building. You have done with a basement. Okay, and you have to create a superstructure on top of the basement. Just virtually doing a basement alone will not solve the purpose. You need to construct a building on top of the basement, keeping into consideration how the basement was done. Was it a sufficient depth of soil was removed? Is the basement sufficient to hold the appropriate height? Now, these are various technical terms and scientific factors which have been taken into consideration before planning an implant. Okay, the next question is, why choose implants? Why cannot somebody choose an RPD or an FPD? In my private practice, or what I feel is, RPD is virtually non-existent. It is literally very tough for the patient to maintain. An RPD is not very easy, first of all. See, it's easier for a student to begin with the processes. You make an RPD, you get an idea of how to replace a tooth. But on a daily basis, as far as the patient is concerned, to wear RPD, to remove the RPD, you go to a social gathering. Sometimes when they speak, the denture pops out. It is very embarrassing for the person. Even though the patient, even for a normal patient, it is very embarrassing. So RPD is not very, very advantageous type of processes. So then we go ahead to FPD. FPD, as you know, in simple terms, you need to virtually reduce good teeth. Okay, teeth with absolutely no caries, with absolutely no periodontal problem. And the worst part is clinically sound teeth. You do an intentional root canal treatment and you virtually extend the amount of problem. See, you have a little space. The problem is restricted to one particular area. In case of FPD, what do? You go to the adjacent teeth, you intensely do an RCT and give a 3-unit crown. So to replace one teeth, one crown, you end up doing more damage, although it serves the purpose. In certain cases, it is fine. But on a routine patient, I don't think now people are, if you educate the patient, they will obviously prefer for an implant. So if you see in this IOPA, you can see 2 implants have been placed in roughly 6 and 5 region. Okay, now, as I mentioned to you, in case in this situation, you want to replace these 2 teeth, what you will do a root canal treatment on the adjacent teeth, do a tooth preparation and give a crown. Now that is what is being done normally. Now, what is the point? What is the problem if you give a crown? So if you choose implants, obviously the adjacent teeth are spared. That is one good point. Lack of secondary caries. Ultimately, if you, most of the time, the clinicians do not ensure a proper fit of the crown on the finish line. So what happens is you do a rough preparation, and I don't know how practical it is to use a impression card for all cases. So what happens, you make an FPD, you deliver the crown. If you use a loop or a microscope, I'm mostly sure that most of the time you'll feel you can see a big gap between the finish line and the restoration. So over a period of time, food gets accumulated and there are chances of developing secondary caries beneath the crown. So on a longer term, on a longer basis, if that caries is very extensive, you can end up losing the neighboring abutments also. So to compensate that, you'll have to extend the preparation. That is another complication with FPDs. The durability, there is definitely documented evidence. The durability of a successful implant is way longer. There have been documented evidence of more than 40 to 50 years of implants in patients. And the ease of maintenance, this is another problem. If you do not choose a proper type of pontic, what happens is you will favor food accumulation between the pontic and the residual ridge over a longer period of time, and the patient is not able to maintain proper hygiene by using a floss or internal brush. It is going to mess up. As an implant, if you give a screw retained restoration, nothing but a small screw, you unwind the screw, you can remove the bridge or a crown, and you can properly do a proper hygiene maintenance, say once in a year or once in 6 months. So that problem is solved in a screw retained restoration. And definitely there is a better masticatory efficiency as far as implants are concerned compared to an FPD. Now, I told you about case selection, which I feel is extremely important. So when you see a patient, do not look only at the edentulous site. In this patient, you can see you have a relatively new crown on 2-1. Whereas if you see the upper and lower anteriors, there are excessive stains, which gives an obvious indication that he has gone a pan chewing habit, or his oral hygiene is not very good or up to the mark. And if you do not educate the patient prior to initiating implant treatment, he might still continue having this habit of maintaining poor oral hygiene, and eventually the implant can end up having peri-implantitis, and eventually can lose that implant. So my point of this slide is, do not see the edentulous space alone. See the neighboring teeth, see the hard tissue, see the soft tissue. Look for, I will talk about various things in the next coming slides, but always, please do not have a narrow vision. Look for other factors also, especially if you have caries in the lower and upper anteriors. It is a strict no. Because if a patient is not able to maintain the anterior tooth and you end up having caries in the anteriors, there are only 2 options. Either you educate the patient, do all restorative treatment and do any abnormalities, like for example crowding, do an orthodontic correction, appropriate restorative management, educate the patient about oral hygiene, and then you proceed. But if you proceed with an implant without treating all this, you are making things complicated. So what is the most important thing as far as implant is concerned is available bone or soft tissue. So as I told you, the implant has to be inserted into the bone. Say, for example, the implants comes in various diameters. It can be starting from 3.3 to say 5.5. One rule of thumb is, if you choose an implant, say 3.7 is the implant diameter, you need at least 1 mm of bone around the implant, surrounding the implants. See, if you take, for example, in the buccolingual direction, implant has got 3.7, you need 1 mm buccally, 1 mm lingually. So roughly 5.7 mm of bone has to be there for a implant placement. If the bone is not there, you have options of augmenting the bone by various surgical procedures. But if the bone is very narrow, say for example, say 2 mm or 3 mm, 1, it is not possible to place. 2, you will have to augment it before placing an implant. For this purpose, you should know to evaluate the available bone and available soft tissue. And what I say to my students or to my colleagues is, patients who do not have time or who cannot afford are not candidates for implants. Okay. You can have people coming and saying that I need to go to abroad in the next week and you need to fix an implant. Yes, there are options where we give immediate implant, but whatever said and done, this is a biological process. It is a surgical process. You need to insert an implant and the implant has to integrate the bone. Now, what I mean by integration is the bone has to fuse with the titanium. This does not happen overnight. For example, in the mandible, it takes roughly 3 months of time. And in the maxilla, it roughly takes 6 months of time. This is the rough average. There are situations wherein people will extract a tooth and place an implant immediately. Now that is called as an immediate implant. So keep these two terms in your mind. There's something called as an immediate implant and loading, immediate loading. Immediate implant is doing an extraction and placing an implant at the time of after extraction is called as immediate implant. And if it satisfies certain criteria, then we can load the implant. What I mean by loading the implant is giving a crown. So when I place an implant and if I achieve sufficient primary stability, which means if the implant is tight enough, if the implant is tight enough, it does not rotate within the prepared cavity. And if it satisfies certain criteria, then you can give a crown. And that too only a temporary crown. But this is not possible in all situations. This is not possible. It is not possible in all cases. So time. The ideal thing will be place an implant, wait for the sufficient time, then call the patient back as a second stage and give a crown. That is more predictable. And affordability, not compromise on the cost because the implant itself is expensive and the materials and the armamentarium which is used for placing implants is also equally expensive, and you need to spend a lot of time and money to get yourself trained. So that also has a specific cost to it. So people would not have money or time, they're not candidates for implants. Or there are various other options where you can refer the people to a training center or to a teaching institution where probably they can do it at a better cost, but not definitely at your individual private practice. So 4 things have to be taken into consideration before planning an implant. 1, history. Okay. I find that many of the time general dentist or most of even some specialists, what they'll do is they'll just ignore the history because they don't ask the history. Only if they ask the history will you ignore it. They are not even aware is the patient diabetic or is the patient got hypertensive disorder or is the patient have some other disorder. Say for example, a patient has got a pacemaker and you're not supposed to do ultrasonic scaling. I don't know on how far extent people go and ask for a history and take it into proper consideration. As far as implants, any disease or any disorder which alters the bone metabolism, you have to be careful. Say for example, for diabetics, if the patient is a controlled diabetic who is able to maintain the blood glucose at a normal level, yes, you can give an implant. For an uncontrolled diabetic, no. So what you do is you refer the patient to a diabetologist, bring the blood glucose under control, and then give an implant. 1. There are certain conditions where patients are prescribed certain drugs called as bisphosphonates. Now these are prescribed for osteoporosis. So what happens is for osteoporosis, there is increased serum calcium because the osteoclast is a problem. So what happens? Only when osteoblasts and osteoclasts work in tandem, there is good bone remodeling. If that is not there, the implant will not survive. And it will be very, it even lead up to osteonecrosis. So to avoid all this, make sure you ensure a proper medical history and only then you proceed. And when you do a clinical examination, give appropriate importance to extraoral also. Why extraoral for an implant? That is one other question which people ask. See, for example, the patient has got a facial asymmetry. Okay, it is very rare for people to have gross facial asymmetry. You might have mild facial asymmetry, which is considered normal, but if a patient is having a gross facial asymmetry, they might have an underlying excessive occlusal problem also. So they can have bruxism, they can have occlusal disturbance, they can have a traumatic occlusion. So from the extraoral appearance, you can somehow gather information about the intraoral problems also. That has to be taken into consideration. Then you evaluate the heart tissue. Heart tissue, what I mean by heart tissue is bone. But fortunately or unfortunately, you cannot evaluate bone clinically in a very precise manner. Although you can do bone mapping and other methods are there, it is not very precise unless you do a radiologic investigation. And soft tissue. Soft tissue, what I mean by soft tissue here is keratinous mucosa. Now, what is keratinous mucosa? Is basically a rough mucosa, which is not mobile. Now, what is the importance of keratinous mucosa as far as implant is concerned is, if there is keratinous mucosa, the resistance to peri-implantitis is high. which means the microbial flora will not penetrate the rough mucosa and it will not invade the implant. So thereby the probability of success of an implant is higher if you have got good keratinized mucosa. And if you find a soft tissue to be deficient, it is ideally recommended to get it regenerated or get it grafted from some other sites. Third point is diagnostic models and wax up. This is one more common mistake what we tend to do, because we tend to skip the model analysis. So when you look at a patient, what impression it gives you is different. When you make a model and when you evaluate the model in all planes, it gives a better idea, especially with relation to the intra-arch relationship. How is the teeth located? Is there any difference? How is the intra-arch space? Is the intraocclusal space sufficient for a restoration? For that purpose, diagnostic models are important. And what I mean by wax up is, wax up, I hope everybody knows wax up. Wax up is a procedure wherein they take the diagnostic model and they'll prepare the rough post-operative crown on a wax. So that will tentatively give you the final outcome, that is the final processes. So based on that, sometimes the number of implants will vary. So that is why wax up is very important. With the wax up, you can also communicate to the patient regarding the final post-operative work process which he or she can expect. Although, please do not give a firm affirmation that this will be the best. This is only a brief idea. And most importantly, do a radiological analysis. Most of the cases, a two-dimensional IOPA or an OPG is not sufficient, although it can give you some idea. It is always preferable to go to a three-dimensional evaluation, preferably a CBCT or a CT. I'll discuss what is advantage of all those. So here you can see a model. If you see the molar on the first quadrant is very close to the lower ridge. Okay, now with this, you can definitely say that the interocclusal space, see, in this case, you can place an implant, but the place for giving the crown is very minimal. So what happens is, one, you can overload the implant on a longer basis, or two, you can end up having post-in fracture very frequently, because you need to understand for post-in, you need to have sufficient thickness, say 1.5 to 2 mm minimum, so that it will withstand the masticate efficiency. If you give a small metal is fine. In this case, you can somehow do with the metal, but if you want to give a porcelain, metal thickness will not be sufficient, and there are high chances that the porcelain can fracture on due course after a long term. So please keep in mind this particular case with this. But when you see the intraoral picture, this is the same picture of the model which I showed you. Can you see the cusp is touching the opposing ridge? Okay. Now, which one to trust? Obviously, it is a clinical version, because you're going to give a crown on the patient, not on the model. So that is the reason I told you, you have to correlate between the clinical picture as well as the diagnostic model. So the patient is undergoing orthodontic treatment with a specific intention of intruding the molar. So a specific device has been given to lift up the molar, so intrude the molar sufficiently so as to give a crown. So here we end up doing orthodontic treatment for sake of an implant. One more option, which is not very ideal, is to do a root canal treatment on the opposing tooth, and you can give a crown. But the problem with that is sometimes you will end up giving a crown on the root of the upper tooth. That also has got a certain minimum space beyond which you cannot give. See, for example, in this case, if you do a root canal, you think you can create occlusal space. What happens is you will end up with only the roots. You will not have crown structure. So restoring that also will be a failure. So the most ideal treatment in this case would be to give a proper intrusion using orthodontics, and then implant has been placed for this patient, but the crown has not yet been given. This is still orthodontic treatment is going on. Once we get sufficient clearance, we'll be placing the crown. This picture, if you see, I think most of you will agree with me that this has not got any specific problems with it. Oral hygiene looks good, teeth looks good in shape except for the edentulous space, and the soft tissue also looks good, a very good keratinized gingiva. Just by seeing this, what you will come into a conclusion is you have missing 2 teeth, you give 2 implants, job is done. So what happens when you surgically open it up? What do you see is you see a defect. Okay, if you see on the label aspect, you can see the bone is not intact. But if you see clinically, it gives a picture as if there is good bone. Now this is misconception. Okay, you will get it from me. Clinically, you will not have any idea regarding what it is. So to avoid this what we do is you take a CBCT or a CT. Now CBCT or CT, for people who are not very familiar with it, it is The only problem with the CT is you think it is difficult to interpret. But if you have the right idea what you're looking at, how to look at it, it is actually very easier. Okay, the CBCT is nothing but it is like, for example, you have a structure. Let's take, for example, you have an egg, a boiled egg. You need to know what is within the boiled egg. How do you do? How do you see it? Just cut it open, you can see it. You cut open a boiled egg, you'll be able to see what is the yolk, where is the white, what is the amount of yolk, what is the amount of white. This is in simple terms. That is one slice break in two. But in CBCT or CT, what they do is they make slices right from the top of the egg to the bottom of the egg. They make many slices. That is, the machine records in slices. Say, for example, imagine 100 slices are made from the top to the bottom. And the computer software will integrate all these slices. It is like a movie. What is movie is basically is a collection of many pictures. And when you run pictures, it becomes a movie. Same way, you have various slices. You just join those slices. You will have such, the software will give you view of one slice in all 3 dimensions. See, for example, if you see in the picture, I have marked, I hope it is visible, that's number 1. And you have number 2. This 1 corresponds to this particular slice. So if you cut the bone in this one place, you can see the ridge here and the lower teeth here. So here the width is roughly 4 mm, which is not sufficient. And slice 2, box number 2, you have 3.5. 3.5 is not sufficient. Even the narrowest implant is 3.3 plus 2 on either sides. You need at least 5.3. So with 3.5, you cannot place 3.3. Simple logic. There is no enough space. So you need to augment it. So that is what is being clinically seen in this picture. Once you open it up, do not think that this crestally you have available bone, but as you proceed superiorly, it tapers. So understand the ridge in all dimensions. This is a very important quote by Stephen Covey, who says, always keep the end in mind. Okay. Do not place an implant and land up in nowhere's land. Okay. You need, ultimately, implant is a prosthetically driven science. The patient does not want an implant, the patient wants a crown. So always keep in mind, where is the crown? Okay. Do you have sufficient bone to place an implant so as to give the crown in the correct position? So that is what, that is why I like this slide. Always keep the end in mind. Where are you going? Are you going the right way? Yes or no? So have a clear idea about which way you are traveling. To explain things in a very simple way, you see a picture on the left where you see a sort of a bridge. Say, for example, it can be a highway, a bridge on the highway, and you have a pillar supporting the bridge, and you have a sort of a mountain slide. Okay. Now, taking this into consideration, there are 2 options. Either you can say the pillar is in the wrong position or the bridge is in the wrong position. Okay. Both things can happen. Now, what is very important, this is the position of the pillar is not very important, because the position of the bridge is important. The bridge, what I mean by bridge, is a crown. What is a pillar here is an implant. And this pillar is standing on a mountain, okay, on the slope of a mountain. So if the slope of the mountain does not have enough soil, the pillar cannot stand. So that slope of the mountain is bone, available bone. Ideally, you will have to have all these things in a straight plane, a proper bridge, the proper pillar, and a proper soil. Or else you will end up in situations like this, where you will do a reconstruction, but you will forget where is the alignment. You will go wrong in the alignment. Now, this is what I meant by keeping the end in mind. So be very clear, where are you going? What is your final destination? Are you doing it? Now, coming back to this analogy of the bridge and the pillar, how do you think you can solve it? I told you the bridge position is very important one. So you cannot change the bridge. So you can change the pillar, soil. If you move the pillar a bit towards the midline, you do not have sufficient soil beneath the mountain. So you need to augment soil. Put soil, put sand, ensure a good basement, shift the pillar to this side. So that is what I mean by putting soil is grafting bone. Graft bone so that you can place implant ideal position. If the implant is in the proper position, you will have good bridge. Now, this is the ideology behind proper implant planning. Now, since I've spoken about proper implant planning, now in this case, you can see a patient has got a missing tooth in one tooth, and you see me putting a probe through a stent. Now, what I mean by this is what I meant earlier. So I told you it's a process-driven science. I should know where is 1, 2, where will be the final position of 1, 2, and through 1, 2, if I make the initial drilling, the angulation will be right. So what you see in the picture below is something called as a paralleling pin. It is nothing but a small metallic device which will be inserted into the prepared osteotomy site. You take an X-ray, verify angulation is right. Now what you see here is only the clinical part. You still do not know where is it going in the bone. So what happens is, if you have, like for example, you see the pin here, the pin may be straight here, but if this portion is like this, again it is wrong. It can be still like this. So this idea, what you're seeing is only this part. The entire thing is within the bone. So take a proper X-ray intraoperatively after every sequential drilling. Make sure the angulation is right, or if it is wrong, make corrections in the subsequent osteotomy so as to make sure that you get a proper alignment. And implant training. Implant training is extremely important. You spend sufficient time, preferably one-on-one training. You get properly trained as far as theory is concerned. Okay, first understand what it is. The best place to learn implants, in my opinion, will be in any teaching institution where you are working or learning for at least 2 to 3 years, because that is the time when you can see the entire stage: implant being planned, implant being placed, the implant being restored, and the follow-up of an implant. For not able to join such institutions, then you can go ahead for various courses which are available in various private firms, but preferably join courses with a longer duration, and preferably get trained on patients and not on models. Models will only give you an idea. Okay, imagine it is not at all, it is a different ball game altogether. The consistency of the model is different. The accessibility, which you can hold the model in a hand, you can place an implant. That will give you an idea about the depth. But in real life scenario, cheeks, tongue, everything is going to hinder you. So always ensure that you get proper training, and which would include a good theory as well as a good surgical training also, preferably overhead training. We call this as overhead training, where you ensure that you get good training with good surgical hands. So one important thing as far as implant dentistry is concerned is it is supposed to be done with the highest level of sterilization and disinfection. It is not like how we do a cavity or how we do a scaling. So instruments have to be sterilized. You should be trained how to handle sterilized instruments, and any type of infection which you can pass it on to the patient can lead to implant failure. So proper autoclaving, proper sterilization is very important. So you get to know proper sterilization protocols, how to handle sterilized instruments, how to do an implant. So ensure that you get a proper surgical training also. And once you go to a proper training, you will be obviously taught about various armamentarium. The picture on the left shows a basic surgical armamentarium which is required for an implant. Can be right from injection BP blade, perios elevators. You do not require much of armamentarium. Any armamentarium which is sufficient for a minor oral surgical procedure will do. And another problem with implants is that most of the implants comes in various systems. Okay, it is not like you see, for example, in endo, you might have heard about ProTaper. ProTaper is one system. When I was doing UG, we used to do with hand files. Now that system is no more into use, I guess, apart from training institutions. So you have shifted to systems. Similarly, in implantology, you have various systems that can be based on various companies from various countries from which they originate, and based on different companies also. Some systems are intercompatible, whereas some systems are not intercompatible. And this armamentarium is nothing but a series of drills. As far as implantology is concerned, precision is very important. You cannot do a rough work. Okay. Now, say for example, you are planning to place a 3.7 mm implant. Okay. 3.7 mm implant is planned. Now the question is, to what diameter should you drill? Should you drill till 3.3 or should you drill till 3.7? Now this question, the answer for this question is depending upon the type of bone. If the bone is a bit soft enough, you can stop just before 3.7, and when you place, the implant will become tight. But if you do this on a soft bone, when you tighten the implant will not achieve stability. Now this is what is called clinical decision making. Whereas if it is a hard bone, even after you place 3.7, it might be difficult to place the 3.7 implant itself. So in such cases, you might have to use something called a cortical tap so as to create few threads, and then you can place an implant. So any system of implants, you should make sure that you understand the system top to bottom and use it in the proper sequence and use in the proper way it is supposed to be used. And the picture which you see on the left lower hand side is something called as a physio dispenser. It is nothing but a motor which will work at certain RPM, and you will have saline attached to it. The purpose for saline is it will prevent overheating. Overheating will cause thermal necrosis of the bone. So implant is like a very precise work done at very atraumatic way. You cannot take an implant and just screw it onto the bone. So this is the basic armamentarium which is involved as far as implantology is concerned. Another critical part of implantology does not stop around the clinic. It extends to obviously the lab. You need to have good lab support. As I mentioned earlier, the lab should be trained, the technician should be trained in implantology. It is not a joke. So people who are not trained, they're not very good candidates for lab support. So ensure that the lab support has got, your lab has got a good technician who is trained in implantology. And if case of any doubts, you should be able to communicate to the lab in person or through phone and clarify the doubts. Because sometimes, take it from me, if you have any, it is like a 5-step process. You have any problem in any of the steps, you will have to repeat from the first. You cannot skip steps, and you cannot say finally we can see. That is not going to work out. See in the picture on the left top, what you see is an impression coping. And impression coping is nothing but a small component which will be inserted into the implant to make an impression. Okay. Now, clinically seeing that, you might think it is okay, but ideally you're supposed to take an IOPA after you fix an implant coping. The reason is sometimes you may not tighten the coping enough sufficiently. It might have gone only 3/4 and 1/4 is still yet to go. So how will you know it? You cannot know it just by seeing. You need to take an IOPA. If you find the space it is not gone, you can further screw it in. Now, what is the difference? You make an impression with the wrong impression coping, that will be reflected on the cast, and that will be reflected on the abutment, and finally your crown will not sit. It will not fit properly on the crown. So that ensure that adequate steps, the precise way at each and every step. You have any doubt, stop it, go back, clarify it, and come back. With doubt, do not proceed, because it is waste of money, waste of energy also. So a good implant technician with good ceramic support, ultimately it is a tooth. After doing all this, you give a hopeless shade selection, the ceramic is not good, it is going to fail. The patient does not know all the anatomy, all the bone availability. The patient only knows is aesthetic crown being given, or else there is no point. So make sure you can also request the technician to give any specific instructions for the incisal shade. Should you need any translucency, what is the type of shade that you want? Do you want any characterization? See, for the previous picture where I showed you, a implant crown was given on a patient with full stains. To make it look more natural, you can add stains onto the crown also. That is called as characterization. Even though it might look uglier, but it will not give a feel as if the crown is very odd. And sometimes the lab sends back to you saying that please check the clearance, which means the technician also knows that there is some problem with the intercrustal space. In such case, revert back to the patient and do any preparation if required. In case of the opposing tooth, make sure that you get good clearance and then proceed. So that is why now these labs are very good labs. They at least have the communication to tell to you that the clearance is not sufficient. So make sure that you communicate with people who tell you the truth. That doesn't mean that there's nothing egoistic to say that I'm a doctor, I've done a good preparation. If it's not good, it's okay, not good. Do the required correction and get back to the case. So if you see this patient as a problem, this earlier case where I showed you between two pictures, like one picture with the normal anatomy, when you open it, you have a problem. So that case I had done Ramus grafting and implants were placed. But if you see the abutment positions on this picture, you see that you compare the cervical line. Do you see here? If the technician gives a crown, it will be too long. Ultimately, it is an aesthetic disaster. I hope you understand. So with line to this, you're supposed to give a crown here. But with this abutment into consideration, you'll be ending up giving a crown here. It will be like two long central incisors, or a central and lateral, comparing to the adjacent thing. Now, this is where a good lab support comes into play. Now, what we do is we give something called as a gingival porcelain. If you can make out, see the level, the CEJ is in level with the adjacent T, and the rest of the area is managed with gingival porcelain. So on a clinical basis, this is the picture clinically, and when you end up giving the restoration, you can because of the technician's good work that he has managed to give a good gingival porcelain, and luckily this patient has got a lower smile line, which means when he smiles, the more than half of the tooth is not seen. So this is not going to be visible. But with the patient with a high smile line, with a gingival smile, with a broad gummy smile, when he smiles, at that time, even this can be a problematic. So in such situations, you will have to go in for soft tissue augmentation. So this smile line has also taken into consideration when and for implantology. Do you get me? I hope the point is taken into consideration. If you have doubts, you can always make a case of an what to say, a 6 retainer with a tooth. Place the tooth and see something like a wax strain. Place the tooth and see how it will be, and then you can make changes accordingly. What we often don't do is we focus on the clinical part when we end up not talking to the patient and educating the patient. Now, what I would feel is when you educate the patient, tell them about the nature of the treatment, the time duration, and the cost involved, and what happens if the implant fails. So all these things have to be informed to the patient prior to the procedure, and not at subsequent times. So when the patient comes, tell to them and specifically inform them about the various other alternative treatments also, and what is the pros and cons of the implants, and let the patient make the decision. Do not force the patient to choose implants. If the patient really wants implants and the patient is the right candidate for implants, well and good. Unfortunately, fortunately, we end up having complications also. It is not all good or great. Anything with surgery is definitely complicated. Whether you like it or you do not like it, you end up having complications. Here is one such complication where you see a implant in the right maxillary sinus. I hope you can focus on this. So this is a case where an immediate implant was attempted. What happens when you immediately extract, say for example, 1/7 is you end up with the interradicular septum. Now, that is the only chunk of bone where it will be inserted in the implant. For some reasons, if the bone is weak or the bone is strong enough, or the insertion pressure is high, you tend to insert at a higher pressure and suddenly it breaches the floor of the maxillary sinus and you end up having the implant in the maxillary sinus. Fortunately for this case, we were able to retrieve it using a Caldwell look approach, surgically making a surgical window, and we were able to take it out. But in case if it is not possible, then there is the only option is doing a FES, a functional endoscopic sinus surgery, which is done by an ENT surgeons, and it is going to blow up the cost. It might be roughly taken to 35,000, 50,000 rupees, and you are exposing the patient to unnecessary surgical trauma also. So how do you avoid it? Preoperative plan. You very well know that bone is less, so wait for the bone to form, or be very careful while doing an implant in the upper posterior regions, or in some cases you can use osteotomes. There's a basically devices to expand the bone, or recently you have denser bursts where they increase the bone height using osteodensification. Those are various techniques, but don't bother. Point to be taken, anatomical considerations. You have a neighboring anatomical structure, be very careful. One more case where I hope you can appreciate the implant being depressed too inferiorly. Obviously, this is not the place where it was intended to be placed. So what you see on the, do not think mandible is a straight bone with sufficient amount of rigid bone. What happens after a certain amount, you have got the medulla, you have the cortex and the medulla. Once you enter into the medulla, it is a kind of a spongy bone. What happens is once you insert an implant, you will feel a certain sense of tightness and you take it for granted. So when you gradually implant, when you insert it beyond a certain pressure, it suddenly dips into the middle and it becomes very difficult to retrieve it also. If it is within the confines of the bone, well and good, no problem. But if it slips into a sublingual space or a submandibular space, it's a big headache. You need to take the patient to general anesthesia, give an extraoral incision, go into space and retrieve it. So a simple way is to be aware when you place, what should you be careful of. One more case where the same thing, immediate implant in the region of lower 7, okay, lower posteriors. In the immediate implant, after you extract, all that is left is not the socket, just an interradicular septum. If the septum is weak, say when you extract, you will transmit the forces to the bone also, to the interradicular septum. That also will be weakened. So when you place an implant, sometimes, see, 80 to 90% of time, you will feel good tightness. It is called as good stability, primary stability. but you'll be urged to give one more turn. So that one more turn can be disastrous. So here it went dipped in, it was managed. And a long-term prosthetic problem is sometimes you can end up having porcine fracture. This can be because of various reasons, because of the lab reason that thing not good, where the technique of addition of ceramic is not good, or you can have a traumatic occlusion, the opposing cusp interfering into that region. So occlusion is also very important. So the financial legal considerations, the total cost has to be informed to the patient. If an implant fails, what happened? What is the significance? Should the patient pay again, or are you willing to take the payment on you? Or if the patient is not suitable for implant, what are the various alternate options? All this should be informed prior, and the time duration. Please give them a time specific criteria. Do not promise them anything which you cannot give. See, people will say that next week I'm going abroad. If you know it is not going to be possible, please say it is not possible. Do not give false promises and don't be on the wrong side. And very important, an informed consent is a must prior to the procedure. What I mean by informed consent is, there is a specific format for an informed consent. You can very well download it from the AOMSI website. AOMSI is an Association of Oral and Maxillofacial Surgeons of India. We have got various consent forms specifically for various procedures, and we have got for implants as well. That will cover all the details. What is the procedure? What is the type? What is the duration? What are the possible anticipated complications? How to handle it? Is the procedure being done under local anesthesia or spontaneous sedation or general anesthesia? Everything will be explained, including the complications and including the alternate options. Let the patient have read, or make the patient read all these things and get the signature prior to procedure. Explain to them, preferably in local language also. So to conclude, what I would say is, the essence of a good implant practice is to learn, to plan, and to execute. Learn properly, plan properly, and to execute properly. It's been only a few years since I've been into this teaching profession, and it gives me a great sense of happiness and satisfaction when I see my trainees do a reasonably good job. Now, all these implants have not been placed by me, it has been placed by my trainees. I've been fortunate enough to have certain good people who have got trained under me, and very happy with the way they have placed. And all these implants are placed by beginners. This is not by experts. For example, the one on the right is the first case of a training, and one on the left is probably the third or fourth case. The one on the down on the right bottom half of the implant is placed by a surgeon who is a bit experienced, but is still not very experienced. But I'm very happy with the parallelism. See the level of parallelism with which it has been placed. See the amount of bone cover, they've been completely submerged. And if you see, especially on the implant on the top right, you see a socket here. This was extracted, and I had advised not to do an implant. Here we placed an implant on the ridge, on a heel ridge. Here, after extraction, we did not advise an implant. We are waiting for bone to form, and probably we can place an implant at a later stage. So this gives me a great sense of happiness when I see my trainees doing a good job. So that concludes my talk on implants, and I'll be happy to share, happy to answer your questions if you have any. Thank you.
Thanks a lot, sir. It was really insightful. I was just following each and every slide, and then it is very well summarized, and in a very concise way you have put some of the things. For me, the takeaways were like, you should that Stephen Covey's thing, like you should know the end even before you start, because nowadays implant is like, yeah, just placing a screw, or you just go, anyone can do it, it's not a big deal. But when we see, it's how delicately and how intricately you need to plan it, what are the complications, and the things that around it. So that was very nicely said. And I was just comparing, like yesterday, a couple of days back, I was in a wedding. So in the wedding, usually you hear a lot of announcements, and in this wedding, the announcement was quite different. So what they said was, like they said the evacuation plan. Say in case of a fire, you need to exit. The exit is here, which you hear in a flight or something. But it was said in a marriage, actually, which is considered an auspicious occasion. But they're talking about fire. In the same way with implant.
Also, sorry to interrupt. It might be symbolic also for the groom or for the bride to escape. It might be taken that state as also.
Understand, sir. Yeah.
But, as you say, that is very important. See, most of the times when you go on a flight, I've seen many people, what do? The moment the air hostess comes with a safety announcement, they sleep, they switch onto their phones, they don't care a damn about what is the thing. It might be a protocol, but sometimes it can save a life.
Exactly, sir. Exactly. I was able to relate it to the implant thing that you are talking about. Though it's very simple, used every day, every time, if we are able to follow these protocols and keep the complications in mind, explain it to the patient. We don't do it basically. We just say, okay, this is the best treatment, very cheap, very affordable for you. Yeah, we'll just do the marketing part of it and fail in educating the patient well. Thanks a lot, sir, for educating us and making us aware and making us think. We have some very good questions from Dr. Arjun. I'm just taking it. He has 3 questions, so I'll take it one by one. And so the first question is, sir, Arjun, Dr. Arjun, do you want to unmute and ask these questions? If you are, if it's possible, or I can read it.
Yeah, sure. Actually, sir, yeah, my first question was about the considerations of deleterious habits such as smoking. The patient might be a long-term pan user who quit recently, or they might be a frequent drinker. There's also a consideration of age. Find personally that older patients are more hesitant. They feel that they won't get a good life out of implants because anyway they're old. It won't really last long for me, or it might cause too many complications for me. So is there a consideration? How do we factor in their smoking or other deleterious habits as well as their age when we plan for an implant procedure?
Okay. First question, age is not a barrier or it's not a consideration. One, as long as the systemic status is okay, and as long as the bone metabolism is okay. Now, what I believe bone metabolism is, they should not be osteoporotic, they should not have any, they should not be having any calcium disorders. So apart from that, age is not a consideration. As far as smoking is concerned, generally implants are not do not have good prognosis in smokers. Now, what I mean by smokers is I cannot include occasional smokers and heavy smokers. But if there's a specific criteria, like for example, various organizations give different criteria. If the patient is a heavy smoker or a chain smoker, we tend to relate that he has got poor periodontal status. If they've got a poor periodontal status, they will have periodontal pathogens which can cause later on implantitis. But implants do survive in smokers who are not chronic, or who are not, say for example, who are not chain smokers, or who are not very heavy smokers. So smoking is not a strict contraindication, but you need to educate the patient about the risk and let them evaluate. And if they give a consent, you can give implants for smokers also. Alcoholics, it is not a strict contraindication. Again, we tend to assume patients who are alcoholic tend to also smoke, tend to have a poor hygiene. The final deciding factor is the hygiene and the ability to maintain good oral hygiene. If it's an occasional drinker and the oral hygiene is fine, that should not be a problem. This is as far as these 3 factors are concerned.
Thank you. Thank you. Next question. Yeah, go ahead.
Yeah, sir. The next question I had was, you were telling us about bone augmentation procedures and how they can be very vital to the success of an implant. So how do we decide between which of the bone augmentation procedures that we should use? Like, do we use GBR or do we use distraction osteogenesis? Especially in the aesthetic zone in the anteriors, where most often people come for implants because they really care about the aesthetics and long-term functionality. So how do we decide clinically which bone augmentation procedure to go for, sir?
Okay. See, for example, what happens is there are 2 types of bone augmentation. Generally, we call as a bone graft or a block graft that is mainly meant for augmenting huge defects or large bony areas. So, for example, for upper anteriors, usually we do a symphysis grafting or a ramus grafting. You can harvest bone from the symphysis or from the ramus. Now, this is as far as autografts are concerned. Okay. Problem with autograft is mobility. You're going to injure a patient and you're going to harvest a bone. But the advantages is you have all the 3 required details for a graft. That is osteoinduction, conduction, and osteogenesis. The probability of success is good. The graft uptake is good, but it is technique sensitive. It is traumatic. It has got comorbidities. Now that depends upon the area of the defect. If the area of defect is huge, you have to do a block grafting. Although you have also commercially available block grafts from various other sources like Alloplast or Xenoplast, but they're very expensive. And the chances are, if the technique is not done properly, the graft tend to resorb. So after you do a procedure, 6 months later on, you call the patient, you virtually don't see any bone. That can also happen. So that depends upon the technique of the procedures. It is technique sensitive. and the comorbidity has to be taken into consideration. But whereas if you place an implant and you find only a single screw to be exposed, okay, in such cases you do not require a block graft. A particular graft will do. A commercially available particulate graft, say a bovine graft, might be, or an alloplast, or sorry, on an allograft or an alloplast, you can probably mix it up with blood or preferably PRF, and you can place a membrane and do a proper closure. Now this is called a GBR, guided bone regeneration, as you rightly said. Now this is meant for small defects. For larger defects, block graft. This is as far as anteriors are concerned. If you're going to the posteriors, there are two options. If you have narrow, if the height of the ridge in the posteriors is less, if say for example you require only 2 mm of augmentation, you can do an indirect sinus lift, that will do. Or if you require say more than 2 to 3 mm, you have to go in for a direct sinus lift. That is surgically cut open the window, lift the membrane, pack the bone, wait for some time, place the implant, or open the window, lift the membrane, place graft, and place the implant at that particular point of time. So that depends upon the height of the bone. Minimal bone, indirect sinus lift. You require a larger defect to a direct sinus lift. Although recent studies have shown that using using densification, you can place implants. This is as far as the augmentation procedures are concerned. But we should definitely take into consideration the morbidity, the cost, and the predictability of the procedure.
Thank you, sir. One last question from Arjun. Arjun, go ahead.
Yeah, sir, the last question I had was, after placing an implant, what are the windows in which we call the patient back for a review? And like for how many years post-implant and post-surgery do we have to monitor the patient for any implant complications or bone resorption around the implant, or any early signs of implant failure, for example? Should it be like within a year our duty is done, or do we call them back for a review even after the first year of the implant placement, sir?
Okay. So generally it depends. Like for example, if you place an implant, you are in the immediate surgical phase. You obviously call the patient on the next day or within a day or two. So looking for signs of inflammation, looking if the wound is healing properly. You remove a suture after 7 to 8 days, and you call the patient. Generally, we tend to wait for 3 months for mandible and 6 months for maxilla. But during this period, it is not required to have a regular follow-up. Now, what happens is you can have probably once in 3 months. Now, before loading, what I'm talking is after placement, before loading. But after you place, the actual evaluation of an implant starts 6 months from loading. So you place an implant, you give a crown, wait for 6 months, and you start evaluating the implant from day 1 after 6 months. So in the initial 2 or 3 years, preferably once in 6 months is better. Because as you said, during this once in 6 months, you do a clinical examination, look for any signs of bleeding or probing or accumulation of food or any plaque, or you take up an IOP, look for any crestal bone loss. That is once in 6 months. Maybe after 2 or 3 years, you can probably have a look at once in a year. But this varies. What I'm talking is about a single tooth implants. But if you give a full mouth restoration based on implants, once in 6 months is very ideal. Because if something goes wrong, you can catch up in the window period of 6 months.
Thank you, sir. I hope your questions are answered, Dr. Arjun. Others, if you have any quick questions, we can take it up. Yeah. If you have any quick questions, we can take it up. Sir is available. We'll have maybe the last 2-3 questions, if at all any questions are there. After that, probably if no questions are there, sir will have any final remarks from his end. A lot of familiar names. Thank you for joining. I hope the thing was useful. Yeah, go ahead, doctor. Someone had asked something, right, sir? There was an unmute. Yeah. I'm not sure. Okay. If there are no other questions, we'll probably have, sir, you have any concluding remarks, sir?
Nothing specific. Just to add one point, anybody can place an implant if they are properly equipped, trained, and they're knowledgeable and skilled. Anybody can place an implant. It is not about the specialty or about the degree of what degree you possess, but proper BDS with good learning of implant, good training in implant, with a good outlook. You should have a good idea. You're always welcome to place implants, and always try to keep learning as time goes. Do not stop with one session. That's it.
Thanks a lot. Thank you, sir. So I think we have come to the end of the session. So I'd like to thank sir formally for giving some time. I know time is very precious for surgeons, especially there's impaction appointments, implant appointments, a lot of things. But thank you, sir, for sparing time and educating us and also giving some awareness. And I would also like to inform the participants that sir also has an implant training center. In case some of you are interested, you can check it out. It's available online. It's called KM Dental Implant Center. So this is my concluding remarks. Thank you. We have a monthly webinar every month. Towards the last week, we try to have it. It will be on some interesting and useful topic. So if you're interested, you can try and join with us, and you can check out our social media channels also. Thank you. Also, this lecture will be available on YouTube. So in case you need to refer back to some of the points that sir has told, you can easily refer back on YouTube channel of us. Thank you, sir. Thank you for joining.
Thank you, Stuart. Thank you for the opportunity.